is diabetes? Diabetes is basically a group of diseases characterized by hyperglycemia caused by deficits in your insulin secretion, insulin action, or both. So we're going to talk about type 1 diabetes, type 2 diabetes, a little bit on gestational diabetes, and you also have your pre-diabetics. We're not going to really talk about pre-diabetics except when it comes to prevention, right? All right, so let's dig. All right, so first we're going to talk about how the body normally reacts, right? And the key players that we're going to talk about is glucose, insulin, the pancreas, the liver, and glycogen. So you definitely need to know this slide, and glucagon as well. All right, so what is glucose? So glucose basically is sugar. Your body needs sugar to survive, because what does sugar do? Sugar fuels the cells of the body so they can work properly, but it cannot enter the cell without the help of insulin. Okay, so remember that part. So glucose is stored mainly in the liver in the form of glycogen. All right, so let's say you went out to a restaurant, right? So you ate your food there, but you were full, right? So you took some leftovers home to eat when you get hungry later on. So that's what your body does. So your body uses the glucose at the time that you need it, right? It uses the glucose for energy. And then if there is some left over, what it will do is it will store it in the liver, and it will be saved as glycogen. So glycogen is your leftovers. All right. Does that make sense? I hope that makes sense. All right. So, insulin. It say insulin is a hormone that regulates the amount of glucose that is in your blood, because too much glucose can be very toxic to the body, and we're going to talk about that later on. So let's break this down into the simplest of terms of what actually happens when we eat. So when you eat, your body breaks food down into glucose, and it sends it into the blood. Insulin then helps move the glucose from the blood into your cells. When glucose enters your cells, it is either used to fuel for energy right away, or it's stored for later use. Does that make sense? All right, so then let's talk about the pancreas. So what is the job of the pancreas? So the pancreas' job is to release insulin and glucagon. We haven't talked about glucagon yet, but we're going to get to glucagon. So if your pancreas doesn't work, do you think that this patient is going to have problems releasing insulin? Yes. Definitely so, right? So let's talk about the liver. So the liver is sensitive to insulin levels and stores and turns your glycogen into glucose when the pancreas secretes glucagon. All right. So, for example, if the body has increased blood glucose levels, or the body has increased insulin in the blood, the liver will absorb and store the extra glucose for later. So please remember, your liver, we're going to call your liver a storage, right? It's just storing it. And remember, your glycogen, that is your what? Your leftovers, right? So if there is a low blood sugar or low insulin levels, the liver will release glycogen, which turns into glucose to help increase your blood sugar levels, right? Does that make sense? I know it's just like Dr. Barnett, slow it down, but it's all gonna make sense. So just make sure you keep reading these terms over and over and over to, piece this pie together. All right, so what is glucagon? So glucagon is released in response to your blood glucose levels to prevent hypoglycemia, which is secreted in the pancreas. So does that make sense? I hope it makes sense for y'all. So glucagon is released in response to your blood glucose level to prevent hypoglycemia. So before we go on to the next slide, I want to make it very clear about glycogen and glucagon. So glycogen is our leftovers. Glucagon basically is a hormone that says, hey, that glycogen that you have saved, hey, we need that because her blood sugar is low. So glycagon is just a hormone that sends a signal to your body to let you know, hey, those leftovers that you have, we need them right now. So I just want to make sure that you guys understood the difference between those. So a normal cycle. So in a normal cycle, you're going to have an increased blood sugar. Your pancreas is going to release insulin. Insulin does what? It shifts the glucose out the blood back into the cells, right? Okay, so to be saved for later as glycogen or to be used now, right? So remember, it's stored mainly in the liver. But let's say that your blood sugar is low. So your pancreas then releases glucagon, right? Which causes the liver to release glycogen, which turns into glucose to increase your low blood sugar levels. I feel like y'all got it. I hope y'all got it. I just want to let y'all know that it is so important that these first 3 slides you understand, because we just don't want to understand what diabetes, oh, their blood sugar is high. We don't want to know how just to treat it, right? Which we'll talk about later on. We need to actually know what is actually happening into the body. So please make sure that you understand your key players and your normal cycle. So what is happening in diabetes, right? So the body is unable to use glucose due to either the absence of insulin, because what is the job of insulin? The job of insulin is to take that sugar that is in your blood and push it into the cells. Why do you need it in your cells? You need it in your cells for energy, or the body's resistance to the use of insulin, or your body is just like, yeah, you got insulin here, but we don't care that insulin telling us to go inside the cells. We're not going. We're going to stay here. So therefore, the patient will become hyperglycemic. Why? Because the glucose just hangs out in the bloodstream, and that can affect your major body organs, which we'll talk about later. So the body starts to metabolize fats for energy. So pause for a second. So if you said, Dr. B, we need energy to survive, right? And our body, basically the glucose from the foods that we eat, right, from the sugar and all that glucose that is in our blood, we either don't have insulin, or our body is just not responding to the insulin telling the glucose to go back into the cells. So your body starts to freak out, and your body's like, we need something for energy or we can't function. So your body then is going to metabolize fats, right? So, and this is not good. So since it cannot get the glucose, remember that glucose cannot enter the cell without insulin. So the body then starts to break down fats, which are ketones, which are acids. So when you are burning fats and acids, this will cause metabolic imbalances, right? So you guys are like, Dr. B, you won't let us go with these fluid and electrolytes, right? But we see how we're about to have some metabolic imbalances. So this happens in type 1 diabetes, or there is a moderate amount of insulin to deal with the fats and proteins, but carbs cannot be used. So this happens in type 2. But we want to just make sure what happens in diabetes is that the body is unable to get that glucose out the blood into the cells, right? So let's dig into type 1 diabetes. All right, so in type 1 diabetes, this is an autoimmune disease involving the destruction of the beta cells in your pancreatic islets of Langerhans, where insulin is produced. So beta cells located in this islets of Langerhans don't work. They have been destroyed. Therefore, the body doesn't release any more insulin. We need insulin, right? what do we need insulin to do? We need insulin to tell the glucose that is in the blood to move into the cells. So treatment for this patient, they have to use insulin. These patients are going to be taking insulin injections, insulin pumps for their entire life. Why? Because their body does not release insulin. We need insulin. So where the production of insulin and all this stuff is happening, there is a damage. They're being destroyed. They're not working. So the patients with type 1 diabetes, they are not producing any insulin, any working insulin on their own. So we have to give those type 1 diabetics insulin. All right, so this slide is about your risk factors for type 1. I want you to remember that this is genetic. This is an autoimmune response. That this is not something that that patient can control. The biggest thing to remember between type 1 and type 2 is that the patient with type 1, 9 times out of 10, they've been diagnosed with this as a child. That's type 1. This is hereditary. This is genetics. Autoimmune, okay? All right. All right, so how is your patient with type 1 diabetes going to look? All right, so your 3 Ps, your polyuria. What's happening with polyuria? They got to urinate so much. And we're going to talk about this in the next slide because your presentations are kind of the same. Your signs and symptoms are kind of the same. So we're going to talk about that later on in the type 2. Polyuria, polydipsia, right? Polyphagia, unintentional weight loss. Why is that patient having unintentional weight loss? Let's think, you guys. Because if that patient is not taking insulin, what they're going to start doing? They're going to start burning fat, right? They're going to start burning fat if they don't have any insulin to push their glucose into the cell. Vision losses. They will have repeated infections, delayed wound healing, numbness and tingling in their hands and their feet. So how do your patients clinically look? So your type 1 diabetics, these patients are young and they're thin. And we talked about why they're thin, right? And remember, this kind of can happen suddenly. Ketones will be present in their urine. So we're going to talk about that some more as well. So let me not get ahead of myself. All right, so how can diabetes be diagnosed? So we have a non-fasting blood glucose level of 200. So what is fasting? Fasting means that that patient has fasted. They have went without food and then they came in and got their blood sugar checked. So maybe I think they went 8 hours or so without food. And then they're scheduled to come in at 8 o'clock that morning and get their blood sugar checked. So if they have a fasting blood glucose greater than or equal to 126, because that means that patient literally had nothing for all these hours and their blood sugar is still high. If the patient has a blood sugar greater than 250, if they have a hemoglobin A1C of 7 or greater. So with our hemoglobin A1C, that is the test that can track basically the average of their blood sugar. And it's not based on if they ate today. It's basically monitors their sugar for over 3 months. Your body, ain't the body like awesome that it's able to like say, okay, within 3 months or so, this is what the patient's blood sugar number runs, kind of sort. So that is great for your patient to tell your patients like, hey, you know that your hemoglobin A1C, that's going to be the tell-all, right? So I know you might be eating healthy. You say you eating healthy while you in the hospital and you've been eating healthy since your last doctor's appointment. But I'm just going to let you know your hemoglobin A1C going to tell on you. So you definitely want to make sure that you know about the hemoglobin A1C. All right, urinalysis. So that these patients with type 1 diabetes, they could have elevated glucose and acetone levels. Even in their urine, right? And we're going to talk about that later on because we're going to talk about it in type 2 as well. So it's like I really don't want to be talking about it 2 times. So just hang on in there. All right. So for they also can have positive glucose and ketones in the urine as well. This patient may be dealing with diabetic ketoacidosis, and we'll talk about that later on. And they will have serum ketones as well. So what do we remember from ketones from the previous slides? That when the body doesn't have glucose, it then starts to break down fat. And when you start to break down fat, it basically are ketones, and ketones are acids, which is bad to be having going on. All right, so let's move on. All right, so you say your patient, they're type 1 diabetic. What are we going to do for them? So we always want to monitor their blood glucose, right? But we want to make sure that we administer that patient injectable insulin, meaning this patient has to get insulin, you guys. We mentioned it earlier. This patient has to get insulin. Why do they have to get insulin? I know I've said it a million times, so I know you guys remember, right? So either they're going to get it through a pen, a pump, if they're doing regular pull-up insulin, but this patient needs insulin. All right. Monitor your hemoglobin A1C, eye exams, daily foot care, and proper nutrition. So you want to make sure that you teach your patient about signs and symptoms of hypoglycemia. So let's say you give your body too much insulin, right? So let's say you had only so remember, the job of insulin is to move it inside the cell, right? So let's say you only have a little bit of glucose in your blood and you give us insulin. What is your body going to do? It's basically going to take the glucose that you have and shift it into your cells, right? And then you're going to have all this leftover insulin that you have more insulin than you have sugar. Do you get what I'm saying? You have more insulin than you have sugar. So that's why you always want to check your patient's blood sugar before you give insulin. So I know in fundamentals 2 that we did checkoffs on mixing insulin and all those things, and knowing how to check the blood glucose and how to follow a sliding scale. So that's why it's so important that you follow your sliding scale. And sometimes you can follow your sliding scale and that patient still bottoms out, meaning their blood sugar still drops. But you want to just make sure that you think of it like that. Like, I have this much glucose, but you're giving me this much insulin. No, that's going to cause our sugar to drop drastically, right? So we don't want to do that. We want to make sure that we're giving enough to push it inside the cell and say, hey, we're going to save you for later, versus then, trying to deplete our storage and deplete everything that we have. Does that make sense? So you want to teach your patient what are some signs and symptoms of hypoglycemia. So your patient may be hungry. Your patient may be fatigued, very tired. You will see that your patient is very drowsy. That's one of the common ones that I know that I see when patients' blood sugar has dropped. They are very drowsy. They're very lethargic. They're all of a sudden so sleepy, right? They're confused. Even they don't even, alert and oriented times for a patient, once their sugar drops, they are now confused. They got dizziness, and headaches is a big one. Headaches. So you want to make sure that you're able to teach your patient, hey, these are signs and symptoms if your blood sugar is high, and these are signs and symptoms if your blood sugar is low. All right?